Welcome to ATCM, the Emergency Medicine Channel. Today I will be presenting a case of a 72 years old female who had complaints of high-grade fever with dysuria, reduced urine output, lower abdominal pain and right flank pain. On 10-second initial assessment, the patient was conscious and oriented, obeying commands. Airway was patent, there were no secretions, and on breathing, air entry was bilaterally equal, respiratory rate of 20 per minute, with saturation of 96% on room air. Circulation, BP was 88, 50 millimeters of mercury, with pulse rate of 122 per minute, with capillary refilling time of 3 seconds. All peripheral pulses were felt equal. The 218 gauge IV cannula was inserted at this point, and she was attached to a cardiac monitor. IV fluids were given. 1 pint NS IV bolus was given. Following that, we repeated the BP again. It was rose to 94/60, and point of care ultrasound was done to check for IVC, and IVC was collapsible completely. So 1 liter NS
What is
IV.
the best IV fluid?
Best IV fluid NS.
NS is not best. NS is cheap and best. It is the most physiological IV fluid.
RL. Plasma.
What is the difference between plasmalate and RL? How do NS different from ringer lactate? How do ringer lactate different from plasmalate? Tell me one contraindication for plasmalate.
Kidney function,
What
higher kidney function, because
What level?
plasmalate has higher magnesium content.
That is the ringer lactate contains more potassium, whereas plasmalate contains more magnesium than any other fluid. But there is a best IV fluid available. It is costly, but only in renal failure we have to be very careful in giving plasmalate. Which condition you have to be careful in ringer lactate? Which condition ringer lactate is contraindicated? Pancreatitis is not contraindicated. One condition it is contraindicated. What is that condition? You should know all these things because these are all basics of emergency medicine. Ringer lactate, normal saline. Plasmalate is only a new thing. Which condition it is contraindicated? It is contraindicated in liver failure. Liver failure is contraindication for ringer lactate because it can produce lactic acidosis there. Otherwise, ringer lactate will never produce lactic acidosis. Okay. So here you are given normal saline. What is the electrolyte abnormality, ABG abnormality seen in large volume transfusion of normal saline? This you see every day. You give lot of IV fluids in patients with sepsis, trauma. What ABG abnormality you observe in these patients? You are near to answer. Near to answer. Hyperchloremia is near to answer. Hyperchloremic acidosis. Hyperchloremic acidosis. So that is the only major lab abnormality you see in patients with high volume transfusion of normal saline, but clinically that may not be significant. Only thing, it can some amount of acidosis to your pH. Okay, so that may produce some confusion. Okay.
And then again, after IVC collapse was noticed, we gave 1 more liter of NS IV bolus, and then maintenance 100 ml per hour was started. After that, disability, GCS was E4 with M6 pupil.
What are the clinical evidence of hypoperfusion in patients with sepsis?
Hypoperfusion, there will be altered mental state, oliguria, anuria. Then clinical signs, CRT will be increased.
CRT will be increased, delayed.
Cold extremities.
And your ultrasound
finding collapsibility.
Okay. What is passive leg raising test?
Passive.
Initially, you don't have ultrasound. What else you do?
Initially, we'll check the BP, and then after that we'll raise the leg and see how much difference in BP.
So now ideally you need to have a central line, then only you can immediately see the result. Okay. Otherwise you check the BP before and raise the legs and see when the fluid from your lower limb coming to the main circulation, whether the BP is slightly increasing. The BP increasing, then what is the inference from that?
The patient has low volume status.
So patient can be given more fluid so that BP will increase. Okay.
Disability. Jesus was E4, E5, M6, pupils 2 mm equal and reacting to light, moving all 4 limbs. Exposure, temperature was 102 degree Fahrenheit. At this point, injection paracetamol 1 gram IV was given. And coming to adjuncts of primary survey, ECG was taken which showed sinus tachycardia. With VBG was taken.
What are the basic difference between sinus tachycardia and supraventricular tachycardia?
In supraventricular tachycardia, there will be it's an error complex.
Rate P wave QRS complex. What is the
rate? Supraventricular tachycardia will be more than 150, around 150.
Maybe more than 140 is supraventricular. Mostly supraventricular tachycardia.
Sinus tachycardia will be less than 140. P wave is absent in SVT.
Mostly it is absent or it is merged in the QRS complex or it is inverted. Okay. In supraventricular. Whereas in sinus tachycardia, P waves will be always present. Okay. What is multifocal atrial tachycardia?
Multifocal atrial tachycardia, there will be different morphology. P waves will be there because of multiple foci in atria. And coming to VBG was taken, which showed a pH of 7.354 with bicarb of 20.6 and lactate was 2.3.
Okay.
Creatinine was 1.5. And coming to secondary survey, we have patient 72-year-old female whose known case of CAD, status of PTC, type 2 diabetes mellitus and PVOD. She now came with complaints of high-grade fever with chills and rigors, intermittent, associated with dysuria and reduced urine output. She was also complaining of abdominal pain, more over the lower side, and also she was complaining of right-sided flank pain also with backache. And there was no history of any hematuria or any giddiness or syncope episodes. Coming to past history, she is the CAD, status was PTCA, done in 4 months back, and type 2 DM, diabetes mellitus with PVOD, and also complications of diabetes mellitus she has had with both eyes proliferative diabetic retinopathy, and left eye significant macular edema resolving vitreous hemorrhage was also there. And also PVOD, she had a gangrene of right third toe and reamputation was done. And she also has diabetic lumbosacral radiculoplexopathy. And medicines she was taking insulin. She was on insulin for diabetes, insulin aspart and protamine she was taking, and sitagliptin, metformin combination tablet she was taking, and atorvastatin, pregabalin, ecospirin, gold, and nitroglycerin was metoprolol XL.
Is a radiculoplexopathy you are told from the previous diagnosis?
Yeah, previous diagnosis.
Okay. What is it? Radiculoplexopathy. What is that? Is it part of diabetes?
Diabetes.
What are diabetic myopathies? They are coming under classification of diabetic myopathies. What are the different types of diabetic myopathies? You have any idea? If you have idea, we'll go. Otherwise, you should not. There are 2 types of diabetic myopathy, proximal myopathies. One is symmetrical proximal myopathy seen in chronic diabetes. Okay, that's what you are telling. It's a plexopathy. But asymmetrically, sometimes acute myopathies can present in diabetic patients. That we have to be very careful. That is treatable actually. But the chronic diabetic myopathy is a chronic condition where plexopathy happens. There will be wasting of the proximal muscles, difficulty in getting up. That is a common problem in all diabetic patients. Okay, acute diabetic myopathies are commonly seen acute elevation of blood sugar. It will be painful, asymmetrical.
And she has no.
The only thing when somebody is writing diabetic myopathy, you have to see whether the patient both the limbs are same or one limb is asymmetrical. Then that is actually treatable. Immediate treatment is available. Okay.
She is not allergic to any medications. And investigations, we had sent a complete blood count which showed a total count of 13.3 and CRP of 218. And also in view of this, we had sent procalcitonin also. Platelet was 1.64, and we had sent RFT which creatinine of 1.52 and urea of 74.6. So it was looking like AK.
Okay.
And then electrolytes also.
AK itself, there are two types. One is AK means acute kidney injury. There are two types of AKs normally. What are the two types? Pre-renal and renal, intrinsic renal problem. So pre-renal means it is mostly due to your dehydration or hypovolemia. That is correctable. But renal means it can be still due to drugs or infections, whatever it is.
And electrolytes are also sent which showed sodium of 130.5 and potassium of 3.6. LFT was also deranged. Total bilirubin was 1.89. Direct bilirubin 0.68, SGOT 91.5, SGPT is at 37.2, INR of 1.11.
Is it male or female?
Female. Then we had sent URE which showed numerous puzzles with bacteria 4+, and we had sent urine culture and sensitivity, and also blood culture and sensitivity. She was having a severe right flank tenderness was present.
Okay.
So we had initially planned for imaging.
Can you tell something about blood culture? We send blood culture for all patients. Is it really required? What is the yield of blood culture in urinary tract infection? How many samples you have to send? Can you tell all these things?
If we are suspecting any bacteremia or sepsis patients, you have to check if it has spread into the blood. In that cases, we can do, or if in critically ill patients, old age patients, mostly they will be prone for infection spreading into blood. So in those cases, you have to send blood culture. If you are suspecting bacteremia or sepsis, then we can send 2 sets of aerobic has to be sent.
Anaerobic has to be sent, but it is highly costly. We know that. So it is, if you are not getting any benefit, better not to send. Okay, because the yield of blood culture in a normal infective focus like urinary tract infection, pneumonia, maybe 30%. Okay, since it is costly, you can avoid it. If you are strongly suspecting something beyond that, like MRSA or pseudomonas, something like that, you can suspect. Okay.
And then in view of the right flank tenderness, we had done a USG abdomen, but that only showed a borderline hepatomegaly. Because of the high procalcitonin result was 61.12. So we had done a CT KUB for the patient.
What is the importance of procalcitonin in emergency room?
We can know the severity of the infection and
is it diagnostic or prognostic?
Prognostic. We can see serial procalcitonin is useful.
Okay.
If it is decreasing, we can de-escalate the antibiotics.
Okay.
So
can even diagnose. It can diagnose the bacterial infection,
or
gram-negative infection. When it is coming down, you can de-escalate the antibiotic, but stopping of antibiotic should not be decided by the amount of procalcitonin levels. That's all.
And then we have done CT KUB which showed bilateral kidneys were bulky with perinephric fat stranding associated with thickening of anterior and posterior pararenal fascia, right greater than left. So in view of the UTI and the urosepsis, we had come to conclusion of pyelonephritis, bilateral pyelonephritis, right greater than left.
Okay.
And then urine culture reports showed E. coli with a colony count of 1 lakh was present, no ESBL with only resistance to ciprofloxacin.
What is ESBL?
ESBL is extended spectrum beta lactamase producing organisms.
What is the importance of that?
In that sometimes in the culture it will show sensitive to the beta lactamase, like
Antibiotics. Okay.
So in that case you have to stop this and change the antibiotics.
If ESBL is positive, you cannot give even normal extended spectrum antibiotics like ceftriaxone or augmentin, whatever it is. You have to go for higher drugs like
fluoroquinolone,
Presilin, Dazobactam, Meropenem, Ertapenem. Okay.
Blood cultures didn't show any growth. So initially, patient we had managed with
Basically,
IV.
if you follow up the blood culture, you can see many patients what you are getting urine culture, sputum culture, they will be negative for blood culture. It is not going to give a good yield of organism in blood culture.
And
But in resource limited settings, you have to reduce the cost of the treatment. If a patient is affordable, then you should take.
so patient was managed initially with IV fluids in view of the hypotension and was responding to fluid.
How do you know that patient is responding?
Initial BP was low with CRT increased and mild tachycardia was there. After giving the fluids, it improved.
Which is the most important parameter in your emergency room that showing that patient is improving with your IV fluids? Urine output. That is the most physiological this one. BP can be increased immediately, you can visibly you can see, but if internal perfusion is improved, then urine output, if suppose there is no renal failure, urine output is the best parameter which can tell you that patient's internal circulation is improved. Okay.
And
Lactate clearance. What is lactate clearance?
uh,
Here lactate is not very high, 2.5.
2.3
So
borderline.
it is not going to help you, but what is lactate clearance? What is lactate clearance?
due to the sepsis component, the initial and the VBG will see the lactate, and after the treatment, after 4 hours, we repeat the lactate. The difference divided by the original lactate will be the lactate.
So what is a significant improvement?
it's responding to.
Responding means what? 10% improvement has to be there. That shows a very good response. Okay. So if it is more than that, it is very good. But at least 10% if we are seeing, then there is a good response for your fluid resuscitation. Suppose the patient does not improve with your fluid resuscitation initially, what else you do?
And then we have to start them on inotropes.
What inotrope is best?
Vasopressor, noradrenaline initially.
Noradrenaline.
We can start.
If the patient does not improve, even after that.
Vasopressin also can be added.
Then steroids. Three steps.
Hypoadrenaline.
One is fluid, second is inotropes,
Inotrope.
third is steroid.
Steroids.
Inotrope, second line of therapy is vasopressin.
Vasopressor.
Dopamine. What is the difference between vasopressin and dopamine? Where will you use vasopressin? Where will you use dopamine? It's all common problems. No? Every day we are seeing.
To increase the inotropic cardiac, chronotropic effect, cardiac contractility, and all we can start dopamine. But more vasopressin, more at
vitamin is
peripheral.
better, no? Vitamin is better in that sense. What is the basic difference of
Dopamine,
dopamine?
vasodilatation at the renal.
Clinically, how do you select? High dose. We don't start high dose now. We start with low dose and increase. What is the basic difference in? See, everything is given in sepsis guidelines, sepsis bundle. What is the first line drug? What is the second line drug? When will you start your what is it? Dopamine and vasopressin. So all standard guidelines are there. If there is tachycardia, what is the ideal choice? Vasopressin. If there is bradycardia, ideal choice is dopamine. There is a basic difference. Rest all things are same. Okay. Then third line of drug is in that category. What is the third drug? So you start noradrenaline, you start vasopressin. Now you understood that cardiac pumping is not adequate.
Adrenaline we can.
Either adrenaline or dopamine.
Dopamine once BP picks up to 100.
Once BP picks up and there is a small element of cardiac failure, then dopamine will be a better choice, or adrenaline will be the ideal choice. Okay.
And we had started the patient initially on injection meropenem.
Okay.
And after that, the culture sense.
How do you give ideal situation? How do you give meropenem?
Meropenem ideally given to patients with complicated.
Yeah, that's okay. Understood the indication. I am asking you, how do you give meropenem to a patient?
Dosing. 1 gram we can give to 8 hourly.
You give that 1 gram. That is very important.
Infusion in sepsis patient. Infusion.
What is that? Why do you give infusion? Why do you prefer infusion?
Because certain concentration, same concentration.
There are two concepts. One is concentration dependent killing.
High dosing
time
dependent and
So this is a time dependent killer. Where meropenem is a time dependent killer. So better effects can be achieved by continuous infusion of the drug. Whereas some drugs you can give concentration dependent killing. What are the drugs which can be used in that sense?
aminoglycosides
Aminoglycosides can be given OD doses, except in infective endocarditis you can give OD dose. Okay, high dose, single dose. Okay, that is dose dependent killer. This is time dependent killing. Okay, but all areas of the hospital this is not practical because these drugs are not very stable in hot, humid conditions. So in ICU you can give, but ward it is very difficult because that stability of drug can come down after few hours.
And after the culture sensitivity report, we had changed it to ertapenem, injection ertapenem.
What is the basic difference in ertapenem and meropenem?
Ertapenem actually this is E. coli, so ertapenem doesn't have, it's a more narrow spectrum.
No, ertapenem is equivalent to meropenem,
but it doesn't have action on
Pseudomonas. Even meropenem has got lesser action on Pseudomonas. What is the basic difference between patient treated with ertapenem? What type of patients can be treated with ertapenem? What type of patients can be treated with meropenem? Both are carbapenems. What is the difference?
OD dosing.
OD dose, where will you use? Which type of patients? Patients with sepsis, ertapenem is not a choice. If it is a local infection like urinary tract infection, ertapenem can be given once daily dose. So once you treat with meropenem, if the patient's sepsis condition is improved, patient is stable, then you can switch to ertapenem, not as a first line drug. If you use ertapenem in sepsis patients, then that is a wrong choice. Both are same category drugs, coverage is same, but it has got no action in the blood. Okay, sepsis it is not a good drug, but local infection is a good drug. Okay. So if you are discharging the patient, then ertapenem will be a choice.
After that, and also the sugars were high, so we had controlled with insulin infusion.
Okay.
After rapid acting insulin infusion was started and titrated, and after the improvement in CRP and total counts, we had stopped infusion and made it into TID dosing.
Okay. What are the advantages of infusion of insulin?
Insulin infusion we can give in case of sepsis or septic shock. If we give insulin infusion, we get better control of sugars, and we can titrate it as per
Most
the
important
values.
advantage is anytime you can stop it.
Also.
So you stop it immediately, the condition will be reversed. Once you give subcutaneous, it can long last, 6 hours or 12 hours. That is a major advantage of insulin infusion. Otherwise, there is no major difference between subcutaneous or IM or IV if the patient has got normal volemia. If normal volume is there, then the moment of insulin is same. But here in this patient, you had a hypotension shock. There, IV infusion will be better choice than subcutaneous. Okay, so you had switched to normal insulin. How much insulin patient was receiving last 24 hours. Then only you can switch to subcutaneous insulin. What was the insulin received by last 24 hours? That is very important. Is it important? Suppose you are giving 100 units in last 24 hours. How do you select your insulin today?
100 units in 24 hours, we'll have to divide into 2/3 dose you have to take. So that will come around 60. Okay. It will come. So 60 we have to divide into 3 dosing.
Okay. Either you give, there are multiple regimes. It depends on the doctor, they change. Some patients we can give TID dose, like 100 units you have, 30 you can give. Okay, some patients may require 5 units. So you can give 10, 20 like that. Okay. So depending on the patient sugar, you can give how much ever doses you want, you can give. Only thing, patient should not go to hypoglycemia. Okay. So the 3 units you are giving now. Today you are giving 3 units of rapid acting insulin. How do you switch to long acting insulin? After few days, 1 or 2 days, there is no need to continue in 3-time injection. Once the patient is stabilized,
That
he is taking
again we'll take the total three.
so 90
three
units
times
we are
involved
giving
and,
now.
90
30, 30,
units.
30.
Then you have to do into 2/3 again.
Okay.
And then 2/3 in the morning and 1/3 of that
So
in the
normally
night.
rapid acting insulin you are giving the 90 units. Only 2/3 of the insulin is required if you are giving a long acting insulin. So then you may require only 60 units. Okay. In that 60 units, 2/3 should be given in the morning and 1/3 will be in the night. So 60 units, 2/3 is 40. So 40 and 20 can be given for this patient during discharge. Okay. Long acting preparations can be given. Okay. So you have two types of long acting preparation, 30-75, 30-70, 25-75 and 50-50. Where will you use 50-50? 50 is rapid acting, 50 is long acting. Where will you use? So all these things we practice in ICU, no? We routinely give on discharge, we give 30-70 or 25-75. That is a usual practice. But some patients we will have to give 50-50. Where will you use it? If the patient is taking lot of food, every time he is taking lot of food, 50-50 is the ideal treatment of choice. If the patient is taking less food,
Okay.
and there 25-75 is treatment of choice. Okay. So large quantity of food means rapid acting insulin's dose has to be very high. Okay. So that also we should remember. Okay. Where will you use analog insulins? So here one question will come. Lot of patients are now on analog insulin, rapid acting analog insulin. Can we continue this analog insulin during acute phase? Can we continue or not? Yes sir.
Not in acute
Eh?
phase. Not in acute phase. Chances of continuing.
Analog insulins can be continued in acute phase. If it is long acting, if it is short acting insulin, that is same as your regular insulin. Only thing is it is costly. That's all. So that if the patient is on regular rapid acting analog insulin, that has to be continued in acute phase also. Okay. Why? What is the difference between analog insulin and normal insulin? If you understand that concept, you will understand why we are continuing. What is the basic difference between two? Huh? So one is a human insulin. After long-term use, it can produce antibodies. Whereas analog insulin is a genetically engineered insulin. There is no antibody production against that. As of now, there is no antibody production. We know. Okay. So in a patient who is taking higher doses of analog insulin, that means somebody has changed that regular insulin to analog insulin because he required higher doses. Okay. So in that case, unnecessarily going back to a regular insulin, and patient may be already having resistance, your sugar may not be controlled with this one. So you can continue it. There is no problem in continuing. That newer guidelines have come, analog insulin can be continued in even in decay, but it has to be a regular insulin, regular analog insulin. Okay. What happened to this patient?
The patient's total count CRP improved. We repeated Procal on day 4. That became down to 6. That's when we started on pertapenem, de-escalated to ertapenem.
Okay.
And then the patient AK also improved. 1.5 became 1.1, and LFT derangement, everything improved. Patient was discharged with ertapenem injection.
How long you have to continue this ertapenem?
We had given for total 14 days.
14 days. Minimum 14 days is required in a patient with complicated UTI like this. Okay.
And then we had followed by tablet, Cefixime tablet was also given for 1 week.
Okay.
Following that.
The patient is improved and we have discharged the patient. Anything else you want to tell? Okay. Anything else you want to tell? Okay. Thank you.
Thanks.